Good morning, doctors. Today we are on the second day of reading Oxford Handbook of General Practice for our MRCGP AKT exam. So let me start reading this. I am Dr. Sesha, your study buddy. Medically unexplained symptoms. Medically unexplained symptoms or MUS are physical symptoms for which no organic cause can be demonstrated. GPs deal with MUS in about 25% of the consultations, and MUS cost the NHS a whopping 3.1 billion pounds per year. MUS causes disability as severe as that caused by illnesses with medically explained causes. Epidemiology. MUS are more common throughout the world in all ages. Risk factors for development of medically unexplained symptoms include females more than males, physical illness or trauma, stressful life events like illness or death or of a close relative, domestic violence, history of child abuse, media campaigns that highlight specific diseases. Classification. MUS can be divided into three types of complaint. Pain of a specific location, example the back pain, headache, fibromyalgia, functional disturbance in a particular organ like IBS and palpitations, fatigue or exhaustion, example chronic fatigue syndrome. Many patients have more than one MUS. There are also common overlaps of symptoms, example patient with IBS often also meet the diagnostic criteria for chronic pelvic pain and vice versa. Concurrent physiological illness. 30% of patients with MUS have an underlying psychiatric problem, usually an anxiety or depression. Underlying mechanism. MUS may be caused by clear trigger, example an illness or chemical exposure, but two mechanisms have seemed to underpin the MUS. Enhanced sense of bodily awareness. Tendency to notify and amplify normal physical sensations such as a heartbeat. Over awareness or increased anxiety, which in turn makes the bodily sensation more likely. Misattribution of symptoms. Rather than normalizing symptoms, example, I have a headache because I have been working too hard, patients with MUS tend to attribute somatic explanations. I have a headache because I have a brain tumor. So these are the two reasons which may cause two mechanisms for underlying for MUS. One is enhanced sense of bodily awareness, and second is misattribution of the symptoms. Assessment. Consider a diagnosis of MUS in any patient with physical symptoms more than 3 months that are affecting functioning but cannot be readily explained. If Even if the patient is known to present with MUS, perform your assessment without prejudice. Patients with MUS have the same chance of developing serious new illness as any other patient. So you should not be biased on your initial diagnosis of MUS. You should do a careful examination for anyone, as there might be some organic cause also. Ask, what are the symptoms? Rule out the red flag signs. How much and what type of impairment do the symptoms cause? What are the patient's concerns about the symptom? Has the patient sought information from other sources like the internet or friends? What made the patient come to your surgery today? What would the patient like you to do for him or her? This is very important. So he has come to you today because he is wanting something, right? So either he wants some medication, either he wants some treatment, either he wants some evaluation. You have to find out from the patient what they want you to do for him or her today. Are there any signs of disease on physical examination? So are the symptoms correlating with the signs? Are there any signs, corresponding signs? Does the patient have low mood or any symptoms of anxiety? Consider depression or anxiety screening questionnaires. So there are many questionnaires. We'll be reading them as and when we come across them. So consider depression or anxiety screening questionnaires. Are there any other social or psychological factors that may be triggering symptoms? Example, a family member or a close friend who is ill. So someone who is ill, that will cause a psychological problem in their friends. So that can be trigger for these kind of MUS. Domestic violence, does he have a debt, work problem, past history of child abuse? These are the things you have to ask and evaluate. Investigation. You have to investigate. Review the patient notes carefully before requesting investigations. Usually investigations are used to clarify diagnosis and reassure the patient and the GP. However, in patients with MUS, more than 50% of patients are not reassured following negative investigations, and 50% false positive results lead to increased anxiety and further investigation. colluding with the patient's increased illness behavior. So, investigations are usually not reassuring for these patients. So, you have to find a balance between appropriate investigation and risk of harm through over investigation. Prior to doing investigations, explain why they are being done and meaning of negative results. Management. Four key areas. Connecting. Go back to the beginning. Listen to the patient. Acknowledge his suffering. Use existing knowledge of the individual, or you recognize that you have no knowledge of the individual. So, either of them, and connect with the patient. Summarizing. Allow the patient to summarize his problems. Recap of your understanding of the problem to the patient. Give an explanation and show your interest in the problem. Handover. Develop a shared action plan or personal health plan with realistic goals to improve functioning and provide reassurance about long-term outcome. Safety netting. Share an uncertainty. Inform the patients about the red flags indicating a serious disease and offer access should some symptoms change. Regular appointments may be helpful, as may a brief physical examination at each visit to check for signs of disease. Offering suggestions for self management, example, doing voluntary work, increase physical activity levels can be useful. Avoid referral unless there is a clear medical indication. General treatment options. If self-help is ineffective, try antidepressant medication. Amitriptyline 10 milligrams at 5 p.m. may be unlicensed. As response is often not dose dependent, start with a low dose. So it is only placebo effect that you are giving them some medicine and that will decrease their anxiety and symptoms. So you don't have to start with therapeutic dosages. You can start with a very low dose. Explain that the drug is not being used to treat depression. Again, these people have a tendency to learn from the internet, so they will Google it up that amitriptyline is used for depression. So the patient will be thinking that doctor did not tell that per se that he has depression, but he will be having depression. So that is another thing. So you should tell them beforehand whenever you're giving amitriptyline, you should say this is not a drug for depression only. It has other treatments also. Like it is helpful in other elements also, and that is why you are prescribing them the drug, and it's not to treat depression in him. CBT. So cognitive behavioral therapy allows the patient to develop changes in thinking or behavior that will help them cope more effectively with their problems. So management of specific MUS. So these are the examples of MUS. Fibromyalgia, inflammatory bowel syndrome, irritable bowel syndrome, chronic fatigue, atypical facial pain, chronic pelvic pain, interstitial cystitis, tension type headache, TMJ joint dysfunction, globus, somatization disorder. Work. Encourage patients to work if possible. Prognosis. 4 to 10% patients with MUS go to have an alternative or organic explanation. Of those with true MUS, 25% have ongoing symptoms after 12 months. So it doesn't, the patient is going to come to you again and again because it doesn't resolve completely in many of the patients, even after 1 year. Somatization disorder. So this, the page numbers here are the pages where the description of this condition is given, and we will read it once we are on that page number. Assessment of pain. So friends, this we are in the middle of my second video, and so if you appreciate what I'm doing and you think it will be useful to any of your fellow colleagues who are preparing for this exam, MRCGP international exam, or for the MRCGP UK exam, AKT exam, for which reading of this Oxford handbook would be necessary, kindly share and recommend the video and my channel, and subscribe and press the bell icon so that you will know that I'm uploading a video and you can watch it immediately. Assessment of pain. Take a history to ascertain what the patient means when he or she complains of pain, the cause of the pain, the severity of the pain. Do not jump to conclusions or make assumptions about the patient's pain. Okay, one more thing I wanted to announce is that there will be a comment section in this video, and in further videos. So if at all there is any particular topic which you want me to explain, because this is only reading what I am doing, but if there are any topics which are doubtful, like management of adult asthma and all, if you can just note it down or request an explanation, a very short explanation about it, so you can remember it easily for your exam, you can just note it in the comment section, so that I can make a short video YouTube shorts about that particular topic, which you can see maybe in a minute or so, and get your topic cleared. Let's continue. Do not jump into conclusions or make assumptions about the patient's pain. Assessment questions. There are many approaches to assessing pain. The specifics of each scheme are not crucial, but it's important the scheme used as a logical outline which works for the individual clinician. A simple mnemonic approach is detailed in figure 8.4. We will see the figure. Always note any past history of addiction to prescription or illicit drugs should be assessed. Elderly patients and patients with difficulty communicating. High prevalence of pain in the elderly population is now well recognized. 40 to 80% elderly people are in institutions are in pain. The reason for this lies in difficulty in assessing those communication difficulties. Additionally, the elderly often minimize the pain, making it even more difficult to evaluate. Methods of evaluation. Unusual behavior and its return to normal with adequate analgesia may be the only confirmation of pain in patients with communication difficulties. Examples include verbal expression, crying when touched, shouting, becoming very quiet, swearing, grunting, talking without making sense. Behavioral expressions, jumping on touch, hand pointing to a body area, increasing confusion, rocking and shaking, not eating, staying in a bed or the chair, grumpy mood. Facial expression, grimacing, wincing, closing of eyes, worried expression, withdrawn or no expression. Physical expression, they are very cold, pale, calming, change in color. Change in vital signs if acute pain, like BP and pulse. There will be change in BP and pulse whenever there is an acute pain. So, pain assessment tools. Sometimes it is helpful to use the pain scales to assess the degree of pain that a patient is in, particularly if communication is difficult. The most commonly used tool is a simple visual analog pain scale. Simple visual analog pain scale. This consists of a line marked in gradations from 0 to 10. Ask the patients to point to the place where the line with which represents how much pain they are in, where 10 is the most possible pain and 0 is no pain. Examine the patient. The cause of the problem may be clear to you from the history alone, but examine the patient to confirm or refute your proposed diagnosis. So, assessment of pain, the mnemonic is Socrates. So, how you will assess in a stepwise fashion. S. Socrates. S. Site of pain. Where? Any radiation? Numbness where pain is felt? Pattern of involvement? Onset. When did it start? How did it start? What started it? Change over time. C. Characteristic of pain. Type of pain. Is it burning pain, shooting pain, stabbing pain, dull pain, pattern of pain, colicky pain, constant? R. Radiation. Does the pain go anywhere else? A. Associated features. Are there any skin or joint changes? Example, bruising, redness or swelling. T. Timing or pattern. Is it worse at any time of the day? Is it associated with any particular activities? Example, movement, urination, eating, passing of stool, coughing. E. Exacerbating and relieving factors. S. Severity record, especially if the pain is chronic, you want to measure change over time. Consider a patient diary. Ask about pain intensity. None, mild, moderate, severe. Rank on a scale of 1 to 10. Record interference with sleep or unusual activities. Pain relief. None, slight, moderate, good, complete pain relief. Figure 8.4. This points to consider when taking a history of pain, that is Socrates. So, one thing in your practice you have to be aware, Beware of emergency requests for opioids from the patients unknown to you or your practice. So someone, a strange patient, first time coming to you and is requesting for opioids, just be aware it could be addiction or abuse. Principles of pain control. Acute pain, symptoms of injured or diseased tissue, subsides as the injury heals and can be worsened by fear. Treat the underlying cause. Chronic pain, defined as pain persisting more than 3 to 6 months, affects near about 70% of the adults in UK. Cause is often multidimensional with physical, social, psychological factors all contributing to the overall feeling of pain. Goals of chronic pain management. Set some realistic targets. Abolition of pain may be impossible because it has been there for quite long. So, abolition may be impossible. 70% have pain despite the analgesia. So, you have to set only realistic targets. If analgesia is not helping, stop the analgesia. The aim is often rehabilitation with decrease in distress and disability. Strategies for pain management. A multidisciplinary approach is essential. Consider prevention like wrist sprints for carpal tunnel syndrome, analgesia prior to a minor surgery, removal of the cause, treat the medical conditions of pain, example, infection, decreased the blood sugar. If diabetic neuropathic pain is there, you decrease the blood sugar, bring it under control. Refer surgical causes for surgery if surgery is appropriate, like hip osteoarthritis for joint replacement. Pain relieving drugs. Start with a single drug at low dose and step up dose or add another drug as needed, especially in situations of acute pain. Step down if pain diminishes. Physical therapies. Acupuncture, physiotherapy or TENS therapy. Nerve blocks. Consider referral for epidural block for low back pain and local nerve blocks or sympathectomy for vascular rest pain. Modification of emotional response. Psychotropic drugs like anxiolytics and antidepressants. Modification of behavioral response. Back pain, consider referral to back rehabilitation scheme. WHO analgesic ladder. Use a step-by-step approach. So first, there is a mild pain, non-opioid should be used like NSAIDs or paracetamol. Step 2, moderate pain. Only weak opioids like tramadol or dihydrocodeine plus or minus a non-opioid like paracetamol or NSAID or NSAID. Severe pain, strong opioids, morphine, diamorphine, hydromorphine, buprenorphine, fentanyl TTS patch, plus or minus non-opioid paracetamol or NSAID. So co-analgesics, drugs, nerve blocks, TENS, relaxation, acupuncture. Specific therapies like surgery for OA, hip, physiotherapy. Address psychosocial problems. This is the World Health Organization analgesic ladder. So step 1. Non-opioid. Start a treatment with paracetamol. Stress the need for regular dosage. Adult dose is 1 gram every 4 to 6 hours with a maximum daily dose of 4 grams. So if this is not adequate in 24 hours, either try NSAID, ibuprofen 400 milligrams TDS if appropriate, alone or in combination with paracetamol or proceed to step 2. So step 2. Weak opioid plus non-opioid. Start treatment with a combined preparation of paracetamol and codeine or dihydrocodeine. Combining two analgesics with different mechanism of action enables better pain control than using either alone. Combinations have decreased dose-related side effects, but range of side effects is increased. Additive effects of two drugs. Combinations using 30 mg of codeine are more effective than paracetamol alone, but it is cheaper and more flexible if constituents are prescribed separately. Like you prescribe paracetamol separately and codeine separately, these are all, both generic medicines, so it's fine. But when you prescribe paracetamol and codeine, cocodamol, it becomes a specific medicine and then its prices increase. So prescribe both of them separately, ask them to take the medicine together. Advise the patients to take tablets regularly and not to assess efficiency only after a couple of doses. So patient takes 2 tablets and then comes back next day in your clinic saying it has not improved. So tell them specifically it is going to take time It is a chronic pain. It's going to take time. So you need to take this course of medicine and then come back to me after the course finishes. There is no proven additional analgesic benefit for preparations containing paracetamol plus 8 mg of codeine compared to paracetamol alone. So 8 mg, that is very low dose codeine, is not effective, has no particular benefit. Strong opioid plus non-opioid. Use immediate release morphine tablets or morphine solution. 2 tablets of cocodamol 500 or by 30 contain 60 milligrams of codeine, which is equianalgesic to 6 milligrams of oral morphine. So as we know, the conversion of codeine to morphine is divided by 10. So this is equivalent to 6 milligrams of oral morphine. If changing to morphine, use a minimum dose of 5 milligrams because 6 milligram is hard to prescribe. You cannot find a 6 milligram tablet. So only 5 milligram doses you will be able to find. Chronic pain may not be opioid sensitive. So opioids cannot be used for chronic pain because chronic pain may not be opioid sensitive. Give for a 1 to 2 week trial and only continue if of proven benefit. If the patient seems responsive to opioids and there are no undue side effects, increase the dose upwards by 30 to 50% every 24 hours until the pain is controlled, and a maximum dose of 120 milligrams of diamorphine equivalent. No, 120 milligrams per day of morphine equivalent. So this is how you have to start and increase the dose of morphine. There were questions in regarding this increased dose. How much dose increase you have to do by 30 to 50%. Take care if the patient is elderly or in renal failure. Consider starting with a low dose of morphine. So addition of co-analgesics and adjuvant drugs in combination with analgesics of enhanced pain control can enhance pain control. Examples are antidepressants in low dose for nerve pain and sleep disturbance associated with pain, in larger doses for secondary depression. Anticonvulsants for neuropathic pain. These are gabapentin and pregabalin. Corticosteroids, pain due to edema. Muscle relaxants, muscle cramp and pain. Antispasmodics, bowel colic. Antibiotics, infection pain. Night sedatives when lack of sleep is lowering the pain threshold. Anxiolytics, when anxiety is making pain worse, relaxation exercises may also help in these circumstances. Referral, if unable to remove cause or unable to achieve adequate pain relief, consider referral to a specialist pain control clinic or palliative care depending on the context of the pain. Be aware of secondary gain from pain if symptoms seem out of proportion, like outstanding compensation claims are a significant negative factor in successful pain management. So, they will tell you that the pain is not managed, or the patient might tell you that he is not having adequate relief because he is planning to get some kind of compensation out of it. So, beware of that. Pain relieving drugs, paracetamol. As an effective painkiller as ibuprofen, no anti-inflammatory effect, but it's a potent antipyretic. Drug of choice in osteoarthritis where inflammation is absent. So non-inflammatory pains, you can give paracetamol as the first choice. Side effects are rare. Overdoses more than 4 grams in 24 hours can be fatal, causing hepatic damage, sometimes not apparent for 4 to 6 days. So you should be very careful not to give anything more than 4 grams in 24 hours of paracetamol. Inadvertent overdose is easy to prescribe of paracetamol in most OTC cold preparations. If suspected, refer immediately to A&E. So see, you are prescribing the patient paracetamol for pain relief. You are giving, a dose of near about 3 grams per day, suppose. And then the patient is having cold. And then he takes an over-the-counter paracetamol and this cold preparation containing paracetamol. So that increases the dose. So if he is taking 3 tablets in a day of 250 milligrams or 4 tablets in a day, so that makes the cumulative dose to more than 4 grams. So we should be very careful in prescribing, and overdose is very common. So if it is suspected, refer to accident and emergency immediately. Non-steroidal anti-inflammatories, NSAIDs, anti-inflammatory analgesic antipyretic. So NSAIDs are anti-inflammatory, analgesic as well as antipyretic. So start at the lowest recommended dose and do not use more than one NSAID concurrently. So don't give two types of NSAIDs at the same time. Start with one. 60% respond to any NSAIDs. For those who don't, another may work. Selective inhibitors of cyclooxygenase COX-2 have low GI side effects but should not be given to any patient with pre-existing or high risk of CVD. So ibuprofen doses, usual doses 1.2 to 1.8 grams per day in 3 to 4 divided doses. So fewer side effects than other NSAIDs, anti-inflammatory properties are weaker. Do not use if inflammation is prominent, example like gout. Higher doses, more than 1.2 grams per day, are associated with increased risk of thrombotic events or MI. Okay, so that is the side effects of ibuprofen. Naproxen, 0.5 to 1 gram per day, 1 to 2 divided doses. So good efficiency with low incidence of side effects associated with lower thrombotic risk than other NSAIDs. Diclofenac, 75 to 150 milligrams per day, 1 to 2 divided doses. Good efficiency with low incidence of side effects associated with increased thrombotic risk, increased liver reactions, drug-induced hepatitis, and compared to other NSAIDs. So you are supposed to avoid diclofenac and ibuprofen because of increased thrombotic risk and MI in any patient. More so in people having pre-existing heart disease. Common side effects, GI effects associated with intestinal ulceration plus GI bleeding. GI side effects are more common in the elderly, people with liver disease or who have high alcohol intake, and those taking continuous low dose aspirin, steroids or SSRIs. You should avoid NSAIDs because concurrent administration of NSAID as well as either aspirin, steroid or SSRIs can cause GI bleeding. Warn all patients about the risk of GI side effects when taking NSAIDs and advise them to always take NSAID after the food. If high risk, more than 50 years, or taking long-term NSAIDs, always co-prescribe a stomach protection. Example, with a PPI. NSAID may also cause exacerbation of pre-existing Crohn's disease or ulcerative colitis. There have been questions regarding this concept. NSAIDs can cause exacerbation of pre-existing Crohn's or ulcerative colitis. Sodium and water retention. This can also lead to deterioration of renal function plus renal failure. Avoid NSAID if possible in patients with renal impairment, liver disease or high alcohol consumption, hypertension or heart failure. When prescribing is unavoidable, monitor renal function while taking NSAIDs. Impairment of female fertility. Avoiding women trying to conceive. Topical NSAIDs of proven benefit for acute and chronic conditions can be as effective as oral preparations. They have a lower incidence of GI and other side effects, although these can still occur. So these are the very important because NSAID is a very frequently and commonly prescribed medication in everyday practice. So you should be aware of these contraindications. Use of opioids is useful for management of acute pain, example following acute injury and cancer pain, especially at the end of life. Little evidence they are helpful for long-term pain. So opioids are usually for end of life pain and also cancer pain, but not for acute or long-term pain. In the UK, 8 to 12% of the long-term prescribed opioid users meet the criteria for current or past opioid use disorder. So general use for initiating opioid therapy. Explain that opioids are most effective for the treatment of acute pain. For majority, 70% of opioids are not effective for long-term pain which require other strategies. Stress the aim of treatment is not complete abolition of pain but a decrease in pain to allow the patient to use other strategies for symptom relief. Warn about the adverse effects including effects on driving. Prescribe initially for a trial period. So opioids you should prescribe for 1 to 2 weeks only and a set of defined outcomes in terms of pain, functional ability and sleep if impaired by pain. Set the rules for stopping the drug. Example, if the outcomes are not achieved in 1 to 2 weeks, if the underlying condition resolves, if the intolerable side effects, or if the patient is found to have abused the medication. So you will set these rules and if any of them are found, you will stop the medication. explained that no further prescription will be issued if the patient does not come for review following the opioid trial. So you cannot go to a pharmacy for a repeat prescription. You have to come back and you have to be reviewed by your GP. Management of prescription opioid misuse. Weak opioids commonly used in primary care include codeine, dihydrocodeine and tramadol. Codeine and dihydrocodeine, the most commonly used weak opioids in UK. Standard adult dose is 30 to 60 milligrams every 4 hours to a maximum of 250 milligrams per 24 hours. Analgesic effect is higher by regular ingestion. 10 milligrams of codeine or dihydrocodeine is equivalent to 1 milligram of morphine. So effects of codeine or dihydrocodeine are reduced by concurrent use of antipsychotics like chlorpromazine, haloperidol, TCAs, amitriptyline, and metoclopramide. So these are the interactions. 5 to 10% of Caucasians have a CYP2D6 genotype and lack a hepatic enzyme needed to convert codeine to morphine. They gain less analgesic effect codeine or dihydrocodeine. So they have to be given morphine directly. Tramadol, a synthetic analog of codeine. Standard adult dose is up to 400 milligrams per 24 hours. It produces analgesia by two mechanisms, an opioid effect and an enhancement in serotonergic and adrenergic pathways. Compared to codeine dihydrocodeine, oral tramadol is absorbed faster, giving analgesia in less than 1 hour with a peak action at 1 to 2 hours. Tramadol is also metabolized in the liver, so it's safe for the elderly and those with a renal impairment. As associated with fewer opioid side effects, notably less respiratory depression and constipation. However, nausea and vomiting can be a problem and rarely tramadol can trigger psychiatric reactions. Always consider co-prescribing a laxative to any patient taking opioids. It's also an important point when prescribing opioids. Opioid side effects are in page 186, morphine and other strong opioids, page 186, further information. So here we are at page 186, morphine and other strong opioids. Morphine is a strong opioid of first choice for moderate to severe pain in both malignant and non-malignant conditions.